Good evening, everyone. How are you all? Welcome to First Aid AMC Clinical Pediatrics Vomiting Cluster. So tonight we're going to finish our first 2 weeks free session, right? So I hope that you guys are enjoying the session so far, and I'm hoping that you have learned the basic approach of these stages that we have done with you. And most importantly, you must have got an idea about how AMC Clinical works and how to at least start your preparation for this exam, right? Now, tonight we'll be doing a little bit of a different cluster. So far, we have done psychiatry, we have done medicine, and now we'll be doing a pediatrics cluster. And you must have an idea about our cluster-wise approach also. And I'm sure that you are loving it because cluster-wise approach makes this classes interesting, and most importantly, it makes your preparation very well organized and concise, and also very smart. So that you don't need to memorize each and every history separately. You can use a format, and using that format, you can do sometimes even 10 or 12 cages. Like today, you'll see that with a single vomiting cluster, how many cages that we are going to do. Okay, so tonight will be our first free 2 week session. So last class of our first free 2 week session. And then we are going to start the full course in rhythm. And you will have a orientation class on this coming Wednesday, which is 25th. And on that class, we will go through some of the important things that we are going to do in this course. And most importantly, how to start your preparation, what else you can do to make sure that you pass this exam as soon as possible. So those are the things that we are going to cover in orientation session. And also we will go through a little bit on the portal, what are the important materials that we have it there, and how to get best out of those portal materials. Okay. So let's start with the pediatrics vomiting cluster. Okay, so as always, with any kind of cluster, we start with a vomiting, like we start with a differential diagnosis. So what are the differential diagnoses of vomiting in a child? So it could be gastrointestinal related, it could be non-GI related. So most importantly, GI related, we have gastroesophageal reflux, pyloric stenosis, duodenal atresia, incarcerated or obstructed hernia, intussusception, could be any intestinal obstruction, such as even volvulus, Hirschsprung disease, all can cause intestinal obstruction. Sometimes even it could be just very simple acute gastroenteritis. And in a neonate, it can be esophageal atresia or tracheoesophageal fistula. So these are all important differential diagnoses of vomiting in children. Then you have non-GIT causes. Children with any kind of infection, they can present to you with vomiting. Not always it has to be GIT related. It could be just UTI causing vomiting, could be testicular torsion, ear infection like otitis media, could be even a meningitis or septicemia, or even a pneumonia can present with vomiting. So we always have to rule out both GIT and non-GIT causes in such differential diagnosis. Now, this is a very, very important cluster for you in the exam because many of these cases are important. So reflux come in exam. Pyloric stenosis is very important. Duodenal atresia, super important. Hernia important. Intussusception important. I have seen questions coming from intestinal obstruction. Gastro, I haven't seen it in vomiting cluster, rather in diarrhea cluster. And esophageal atresia also important. As you can see, all of these cases are exam cases. So this cluster is super important. Okay. And non-GI causes, I haven't seen that much except UTI to come in the exam. Testicular torsion comes, but it comes under groin pain or abdominal pain. Okay. So let's start with our cluster-wise approach for vomiting. So first we start with the history. Pediatric history is a little bit different than the medicine or psychiatric history. So there are a few new things that you are going to learn today. So first of all, if it is an acute vomiting, like the child just started vomiting, let's say 1 or 2 days ago, obviously in that case, first the approach remains the same. You will introduce yourself with the parents. In exam, you don't get the children as a role player. You will get their parent as a role player. So either the father or mother will be there as a role player to talk to you, not the children. So first of all, you will introduce yourself. You will reassure the parent that you are going to take care of the child, and then you will make sure the child is vitally stable. So we're talking about online exam, and then you start the vomiting questions. So you must know our approach by now because we have been doing these classes for a while now. So first of all, we will say that hi, excuse me. Let's say Jenny is the mother name. Hi Jenny, this is Dr. Arshan. I'm one of the doctor in this hospital. It is very nice to meet you. I understand from the note that your child has been vomiting for the last several days. I'm very sorry to know that. Your child must be suffering a lot. But now that you are here, we are going to take care of him. Before I ask any more questions, I will make sure that he is vitally stable. So I'm going to take his blood pressure, his pulse, any sign of dehydration, and make sure he is stable enough. Is that okay with you? Yes, doctor. Well, now, Jenny, would you please tell me a little bit more about his vomiting? So this will be your initial approach for online exam. And then with that, we will start with the vomiting questions. First of all, when you ask an open-ended question, they will give you some information. Yes, doctor, he's been vomiting for the last 2 days and it's just gradually getting worse. So whatever you have already got from them, don't ask it again. But you need to find out when did it start, how many episodes so far. We always use CCVO for any kind of discharge from the body. So vomiting, bleeding, any kind of discharge, we use the CCVO. So C means color, another C is consistency, V is volume, and O for order. So first ask that what's the color of the vomitus, any blood in it, and what is the main content of the vomitus. So is it just a breast milk or the food? So we want to know the content of the vomitus. Is it a small or large in amount? And is it very foul smelling? Is it forceful or projectile? So this is a very important question because forceful projectile vomiting suggests pyloric stenosis. Not always that just because a vomiting is forceful and projectile, it has to be pyloric stenosis. It's not like that, but just be careful about this. These are some of the clues that you will get in pyloric stenosis children. So have you noticed that the vomiting is forceful or projectile? And then ask, does the vomiting has any relationship to food or feeding? And if they say yes, then how long after feeding or how soon after feeding does he vomit? So relationship to food is important. Sometimes patient who has got upper GIT issue, they usually vomits immediately after feeding. Okay? Something in the lower GIT, like intestinal problem, they take some times for the vomiting to happen. Then say, does he become hungry immediately after feeding? Now that suggests that he's vomiting a lot, that every time you're feeding, the child is vomiting everything out. That's why he's becoming hungry and he starts crying. So these are the vomiting questions that we ask in here. So first of all, CCVO, and then forceful or projectile, any relationship to feeding, and does he become hungry immediately after feeds? Okay. So that's all the vomiting questions that we are going to ask. After vomiting, along with the vomitings, we are going to ask some associated questions. Now, if you don't remember the associated question, you can just start asking the differential diagnosis. That's fine. Okay? Because in here, we will be asking some of the DD questions anyway. So for differential diagnosis, we start with the GIT related causes. And if you remember the associated symptoms, so you can ask along with the vomiting, any associated tummy distension, any lump in the tummy or in the groin. So why we're asking about tummy distension, vomiting with tummy distension, likely it could be an intestinal obstruction. Okay, so if you forget to ask this, you have intestinal obstruction differential diagnosis anyway. You can ask these questions while you are asking this differential. Okay, no problem if you miss that. So start with the GIT causes first. So for GIT causes, you have intestinal obstruction. So ask about how about his bowel habit? When was the last time he opened his bowel? Any history of diarrhea or constipation? And in this time, you can also ask about any distension of tummy. So that will cover intestinal obstruction, especially if there is constipation history and the last bowel motion was maybe 2 or 3 days ago, then you can think of intestinal obstruction. Ask about diarrhea. So diarrhea will cover gastroenteritis, which is also one of your DD. Okay. Now, it's not a bad idea to start with bowel and bladder at the same time so that you don't miss it. So you can ask after bowel habit, you can ask how about his waterworks? Any change in the number of wet nappies? Any change in the color or smell of the urine? And does he cry while passing urine? What does this mean? There are two questions we are asking here. One is about UTI. So UTI question is any change in the color or smell of the urine. So UTI, the parents sometimes say that yes, the urine is smelling funny. So that's one clue. And because of burning sensation while passing urine, children, they can't say that it's burning or stinging. They will cry while passing urine. So does he cry while passing urine? Now, sometimes if the child is vomiting a lot, they can get dehydrated and their number of wet nappies can be reduced. So that's why we are asking any change in the number of wet nappies. Then we have intussusception as one of our GIT related DD. So ask about that. So did he or does he draw up his legs while crying? You can also ask that, have you noticed that he's having episodic screaming or crying? Okay. So we want to find out, is there any episodic screaming or crying episodes? Because sometimes in intussusception, they get say episodic crying or screaming. And during those episodes, they draw up their leg up to the chest as if they're in severe pain. Okay, so you can ask about that, any episodic screaming or crying, and if yes, then does he draw up his legs while crying? Does he turn pale or blue while crying? Okay, so that's intussusception question. And if you come back to the differential diagnosis, you can see that there is not much to be asked from here. So gastroesophageal reflux, it's something which will not just happen acutely. It will be ongoing for several weeks, and the main finding will be child vomits after feeding. Okay, and everything will be fine. Pyloric stenosis, there will be vomiting. So the because it's the stomach opening is narrow, so there will be breast milk which will be vomited. So whitish vomit. And most importantly, it will be, and sometimes it can be acute onset also. And with pyloric stenosis, sometimes you can also get the child is getting severely dehydrated, not gaining body weight. So those will be the main finding. And also a forceful projectile vomiting. Duodenal atresia, we will come to this later on, but it usually happens in 24 hours within birth. Incarcerated hernia, we already asked a question that have you noticed any lump or bump on the tummy or on the groin? So if there is a lump or bump in the groin, then we would think about a hernia. Okay. Then you have got intussusception, which we have already asked. Intestinal obstruction we asked. Gastro we asked. Same with esophageal atresia, nothing much to ask. It will also present within 24 hours after delivery. UTI we asked. Testicular torsion for, you can ask that is he, if the child is like 5 year, 6 year old who can complain about the pain, then you can say that is he complaining about pain, about any pain on his groin or testes. Then after that, let's move on. So then we have some non-GIT causes. So we have meningitis, otitis media, and pneumonia. So for meningitis, you can ask any fever, any rash. For otitis media, any discharge from his ears? Does he keep pulling his ears? Now, pulling ear is mainly for infant who can't complain about pain, but for a 5-year-old, they can complain about pain, or even a 2 or 3-year-old can complain about the pain. So for them, you will be asking, is he complaining about any pain in the ears and any discharge from ears? For pneumonia, any cough, any shortness of breath, or any difficulty in breathing. So these will be your non-GIT causes. So far we have done vomiting questions, and then we have asked all the differential diagnoses, including GIT and non-GIT causes. After that, every pediatric case finish with this well baby question, BINDS. Sometimes we also ask TMAC, and then past medical history and family history. So what we have got in here, so well baby questions. Now I haven't written any notes here, but these notes are given in your portal under respiratory system. So then in the next few days, we will be doing a respiratory cluster with you. In that case, you will be seeing all the notes about this well baby, BINDS, TMAC. Now coming back to well baby questions. So for well baby questions, we ask several history. First of all, we ask about the mental health or mental status of the baby. So for mental status, we ask that, do you think your child is active, alert, or drowsy? So active, alert, or drowsy is the mental status. Second, we ask about pee and poo, which is bowel and bladder, which you already asked in the differential diagnosis. We also ask about feeding and sleeping. You can ask here that how about his feeding and sleeping? Is he able to keep anything down below, or everything he is vomiting out? And number 4 is any loss of body weight. Okay, so these are the 4 questions that we ask in every children as part of a well baby questions. All good? After well baby, there is also another thing called BINDS. So what is the BINDS? So BINDS is a mnemonic for few questions that also we ask in almost every pediatric histories. So B for birth history. In the birth history, it's a relevant birth history. If we want, we can ask 10 or 12 questions in terms of birth, but because this is a long history, you will be just asking that, how was the birth? Was there any complication? Was he a term baby? Okay, so just that question will be fine. So how was the birth? Was there any complication? And was he a term baby? I for immunization. So is he immunologically up to date, or have you given all the vaccines to him? So immunologically up to date is for I. N for nutrition. Nutrition is not very important in this particular case, so we forget about it right now. Now D for diet, and sometimes we put drugs, but again diet in here, we're already asking about feeding and everything, so not very important. Sorry, in D, it's not about only diet, we also put development. Now, development is very, very important for this kind of cluster, because sometimes if everything out, it can cause significant growth and development loss. So what we will be asking here is that, how about his growth and development? Do you have any concern? So growth and development, most of the time, if it is a chronic problem, especially, let's say if it is a pyloric stenosis, child is not eating that much, or whatever child is eating, everything is vomiting out. So they will have like reduction of their growth, especially reduction of body weight. So growth and development will come under D. And you can also keep diet in here, but diet will be basically covered under nutrition anyway. And then S for social support. So social history or any kind of familial support. So social history also not very important in this particular cluster. So under BINDS, it's always relevant thing we will ask. For this cluster, birth history, immunization history, and development history is the most important ones. After we have done the BINDS, then we will go to the TMAC. So TMAC has some mnemonics in here. So let's just do one thing in here. So we'll just erase this part. Now, TMAC is not for every children. It's always relevant. So T for travel. Travel history has nothing to do with the vomiting. So sometimes if it is an older child and the parents went for a travel to, let's say, South Asia, maybe Thailand or maybe Indonesia, then sometimes it can be a gastro that we can think of, but not super important in here. M for medication, A for allergies, and C for contact. Contact history is super important for children. Okay. So in here, you don't need to ask about travel. You can ask about, is he on any kind of medication, any known allergies? Now for contact, you have to ask two questions. Anyone at home having the similar symptom? That can be gastro. Does he go to childcare? Anyone at childcare recently had some symptoms like this, or anyone at childcare had similar symptoms. So home and childcare contact is very important in here. So ask about it in this case. And lastly, finish with past medical history and family history. Okay. So it seems like a lot of questions, but if you know if you know how to ask relevant questions, then it's not very hard. Okay. Any question with the history? A for allergies. So to give you a summary of this cluster, because the history forms the main part of this case, so you'll start with the introduction, reassurance, make sure child is vitally stable, then ask the vomiting questions, then ask one by one differential. So you start with the bowel and bladder, then ask about intersusception, don't forget about hernia, then non-GIT causes such as meningitis, otitis media, and pneumonia. So this will be your main DD. And then very quickly ask about well baby, binds, TMAC, past medical history, and family history. Okay. So that's all about the history of vomiting cluster. Now let's see some of your questions. Is this course for someone starting preparation from the beginning, and do you provide the material before or after the class? So yes, this is a course for beginners, obviously, and it's not just for beginners. It covers every kind of people. Maybe if you are in the beginning part, that's fine. If you're in the middle of your preparation, that's fine. Even if your exam is very near, this is also fine. Okay, materials are usually provided in our portal, and most of the materials are given before the class, except the role play sessions. Okay, so let's start with the cages, and during the cages, we'll go through some of the physical examination as well. So the first cluster questions is urinary tract infection, very important for pediatrics. So a mother came with 9-month-old female baby with fever and vomiting for the last 2 days, and you are a GP. History, physical examination from examiner, diagnosis with further management. Okay. So a mother coming with 9-month-old baby. So every children who is less than 12 months, they are high risk, especially if they're having a fever and vomiting, because we are always concerned about the septicemia. So any less than 12 months, fever, vomiting, we should be concerned. So you'll take a history, physical examination. Now, this is actually physical examination for face-to-face, but in case of online exam, as I said, that there are two forms of physical examination. So either physical examination card will be given, or they might ask you to explain what examinations you are going to do with the examiner or with the patient. So in this case, the main history of presenting complaint is fever and vomiting, right? So your initial introduction and everything is same. You'll start asking questions about the fever, vomiting. So obviously, when there is two presenting complaint, we always ask that, I understand from the notes that your child has got fever and vomiting. Which came first, fever or vomiting? Whatever comes first, we start asking questions about that first. So if fever comes first, then since when the fever start? And did you measure the temperature? What was the highest temperature? Is it continuous or on and off? Any chills or shivering? And did you give any medication? And if that helped. So those are the fever questions for every fever. Vomiting questions remain the same, so CCVO. Then go to the differential diagnosis one by one. Now, when there is fever, we are always concerned about the infectious cause, right? So infectious differential diagnosis will come first. So most of the non-GIT causes that has fever, because those are infection, meningitis, otitis media, pneumonia. So that will be your first questions in here. So we do this head to toe fever questions. So head to toe, all the fever source questions you are going to ask. So from where the fever or infection has come, you are going to ask head to toe. So on the head, what can be the infection? Meningitis, encephalitis. So ask about any rash, okay? So any rash, any fever or vomiting, you already know there is fever and vomiting. So just ask about any rash. Depending on the age of the child, if it is more than 2-year-old, you can also ask about any neck pain or stiffness. Does the light hurt his eyes, which is photophobia? Okay. So those are all meningitis questions. So rash, neck stiffness, photophobia. After head, you have got all the upper respiratory tract infections, right? So ask about any runny nose, any sneezing, any watery eyes. For the ear, ask about any ear pain or any ear discharge, any sore throat for tonsillitis. And after upper respiratory tract, you have got lungs. So ask about pneumonia. So any cough, any breathing difficulty. Then what we have got, abdomen. So GIT. So we have got gastro and UTI. So for gastro, you're going to ask the bowel habit questions. So all those bowel habit questions. So how is his bowel habit? When was the last time he has opened his bowel? Any diarrhea or constipation? So all the bowel questions, and then all the UTI or water work question. All right. And after that, just quickly ask the GIT differential diagnosis question, which is your hernia, intussusception, pyloric stenosis, and reflux. There is not much to ask from this, but for hernia and intussusception, we have questions to ask. Then lastly, finish with well baby, binds, any past medical history, especially if you understand from the history that this case is a UTI case, ask about any past history of urinary infection, any family history of kidney disease, any past history of any kidney disease. Okay. So that will be your all the questionnaires in this case. Physical examination. So this child has got fever and vomiting. So in your physical examination, you will be covering also all the infection questions or all the infection examination. So for physical exam, first you will start with the general appearance, and you will be looking for if the child looks active, alert, or drowsy. Any dysmorphic feature of Down syndrome. In the pickled, the main thing is sign of dehydration. So even after that, you can look for any pallor icterus, but most important for a vomiting children is sign of dehydration. So any sign of dehydration. So what we look for in the dehydration, we look at the capillary refilling time, sunken eyes, dry mucous membrane, and also skin pinch test. After that, you'll be checking the whole skin for any kind of rash that you can get for meningitis. Then you would check the vitals, most importantly temperature, ask for any growth chart. So growth chart is must for every pediatric physical exam. So we say that we would like to check the growth chart to make sure child is growing well. After growth chart, we will start with the ENT examination. So ear, nose, and throat exam. We will check for any neck stiffness, and then we would go for systemic exam. So start with the abdominal examination. So on abdominal exam, we will do the whole examination. So inspection, palpation, auscultation. And then we finish with other systemic exam. And we also look for any office test. Now, I know it's a little bit confusing to you that what we are doing right now. So what's you after taking the history, as I said, there are two different kind of tasks can be there. One task can be just physical examination card is given, and you just need to read the card and then explain the finding later on with the parent. Or the second task would be that explain what physical examination you are going to do with your examiner. And after that, a card will appear on the screen with the findings. Okay. So if this is the task, then you will need to know that what physical examination you are going to do in this child. So in that case, you will finish everything to the examiner. So you will say, dear examiner, I'm going to do a physical examination on this child, a 5-year-old or a 9-month-old who presented with fever and vomiting for 2 days. First, I will start with the general appearance, making sure the child is active, alert, or drowsy. I would check for any sign of dehydration. So I will check capillary refilling time, skin pinch, any dry sunken eyes, or any dry mucous membrane. I'll check the rash, check for any rash to rule out meningitis. I would check the vitals, starting with the blood pressure, pulse, temperature, and respiratory rate, and with oxygen saturation. I will also make sure the child is growing well, so I will do a growth chart. Then I would start with a ear, nose, and throat examination. On ear exam, I will check for any tympanic membrane changes or any sign of infection. On the nose, I will check for any nasal mucosal changes or any nasal discharge. On the throat, I will check for any sign of tonsillitis, such as tonsillar enlargement or hypertrophy or any other exudates. I would also check for any neck stiffness to rule out meningitis. Then I would do a focused abdominal exam, starting with an inspection, looking for any visible distension or any visible peristalsis or mass, which can be found in pyloric stenosis or sometimes in intussusception. Then I would do a palpation, checking for any palpable lump or any tenderness. Then I would check for any audible bowel sound. And lastly, with the consent of the parent, I will check the hernial orifice to make sure it is not an obstructed hernia. If there is any if there is any indication of testicular pain, then I will also check the genitalia for any sign of testicular torsion, and also a paranal inspection for any sign of diarrhea. And at the end, I would finish with all other systemic exam, including a respiratory system, cardiovascular, and central nervous system examination. And I would also check for any urine dipstick available, looking for any leukocytes or nitrites. Thank you, examiner. So that will be the case in here. If something like that comes in your exam, then you just need to explain what are you going to do, and that will appear on the screen. Here. Now,
वो काफी अर्सा मैंने
this,
किया मगर उसके बाद ना मैंने जो है
sorry, please don't unmute yourself, guys. Like, I'll just keep everyone muted. Now, in this case, what happened is that this is a 9-month-old baby, had a fever and vomiting. And on the physical examination card, sometimes you will get that they have done a urine dipstick, which showed leukocytes or nitrite. And sometimes for a 9-month-old, the only symptoms might be fever and vomiting, because there might not be any other symptoms. So don't just think that there will always be, child will cry while passing urine. So those symptoms might not be there. So you might just get fever and vomiting, nothing will be positive. And then when you do the office test on the urine dipstick, you can get a leukocyte and nitrite. Then you will know that this is a case of urinary tract infection. Yes, Dr. Jamshina, if you forget something to ask, we will not be given that finding. No, it's not like that case. Now, the thing is that it is a card which will be given to everyone. So they can't delete in that way. So in online exam, the card will be given anyway. Like if you ask or not. And is this approach applicable for online exam? We are doing an online exam approach, Dr. J. We are not doing anything related to face right now. Okay. And do we state like anatomical landmarks when asking for physical exam? You don't ask physical exam from examiner in online exam. Okay. So it's not the face-to-face where we have to ask the finding and then examiner will give it to you. So most of the time in online exam, a card will be given, and on that card, all the findings will be given. So you don't need to even ask anything. And I said that in the second one, sometimes they can say that just explain what are you going to do, and then examiner will give you the finding on a card. Okay. Now, let's say we already know that this is a urinary tract infection. So what are you going to explain here? So you will say that from history physical examination, and if you sometimes get the finding on the card, you can say that from history physical examination, and also we have done a urine dipstick on your child. It found that there is some sign of infection in your child urine, which is what we call as urinary tract infection. Are you with me so far, Jenny? Do you understand what I am saying? Yes, doc. So urinary tract infection it's an infection of the urinary tract caused by a bacteria or bug. As this tract is very close to the back passes, sometimes bugs or bacteria can easily enter into the tract, causing infection and inflammation, and that can manifest as fever, vomiting, and sometimes even a painful, burning, smelly urination. As your child is still 9 months old and is considered to be one of the vulnerable group of patients, I need to send your child to the hospital by ambulance. In the hospital, she will be seen by a pediatrician for further evaluation and management. Now, you can ask me that, does every UTI child need to go to the hospital? It's not like that. Sometimes we take the decision based on how severe the child looks like. Even sometimes in 9 month old, if the child was not vomiting that much, we might not need to even send the child to hospital. We could give a try with oral antibiotic. But given the child is vomiting, oral antibiotic might not even work. So in those situations, it's must that you have to send the child to the hospital. Okay. So it is a 9 month old child, vulnerable group of patient, can get septic. So you have to send the child to the hospital where they will be seen by a pediatrician or child specialist. Now, the next thing is that as the initial urine dipstick is just a screening test for the infection, most likely the specialist might want to take another sample, probably by a method called suprapubic aspiration, and then send the urine for culture to confirm the diagnosis. In this procedure, a needle will be inserted just below her belly button, and then a sample of urine might be collected. Please don't get scared. It will be totally pain-free and will be done by a very experienced doctor. Okay? Are you with me so far, Jenny? Yes. And once the urine sample is taken, a specialist might also start your child with an antibiotic to fight the infection and just a simple paracetamol to address the fever. Now, sometimes they might also want to do further investigation. And those usually they do if your child is getting a recurrent urinary infection. The main reason of doing those investigation is to make sure that your child hasn't got any structural abnormality of the urinary tract. So they can decide to do an ultrasound of our urinary tract to make sure everything is fine. And sometimes even, especially in recurrent infection, they might also want to do another test called micturating cystourethrogram, where a special dye is inserted into the urinary tract looking for any abnormalities. But this will be decided by the specialist, and most of the time, this is not done in the first infection. So you don't need to worry about it. Please don't get scared, Jenny. I do understand that sometimes for a little, sometimes it looks very scary for our little ones to have fever and vomiting and looks like they're suffering a lot. But most of the children with urinary infection, they usually get better without any future complication. It's always important that you wipe your child from front to back and make sure he has ample amount of fluid. I will give you some reading materials on the way to your hospital, and I would like to review her after she is discharged from the hospital. Okay? So this is how we are going to finish this case. There is a lot to learn from UTI. What I would suggest you is to read the RCH guideline, and RCH guideline will give you a little bit more basic ideas because the scenarios can change based on the age of the child, based on how many times the child has got the infection. Okay, so read the RCH guideline at least once so that you get all the updated links and everything. Okay, that will be important and helpful in the exam. Few things are important, and you can ask me questions directly. So, does every child needs a suprapubic aspiration? So that's Dr. Milan has asked. Very good. So it's not like every child will require a SPA. It's the only group of children, especially less than 12-month-old, will need the suprapubic aspiration because we can't rely on the dipstick, and most of the time those are contaminated and falsely positive. So most of the time you have to go for a suprapubic in this group. After 12 months, then sometimes you can try clean catch urination. So children, if they are able to void on request, then parents can try to catch the urine. So that's called clean catch urine. That can be tried. Children more than 4 years of age, they can do the MSU, which is the midstream urine, because most of the time they can void with request. So less than 1 year, SPA, 1 to 4 years, most of the time you can try a clean catch urine, and more than 4 years, then you have to go for MSU or midstream urination. Okay. Now they can ask, how about bag specimen? Bag specimen is not a reliable test, and most of the time that can be contaminated externally, and it can compromise the test result. So it is not an indication. Okay. So the main thing is when you explain what is the condition and then say why the condition has occurred. So it has occurred because of a bacteria, and how did the bacteria cause the infection, and what is the main symptom of it. And then talk about if there is any investigation and further management. So first of all, as part of the management, you can't do anything in your GP clinic. You are sending the child to the hospital. What will happen to the hospital? First investigation, which is suprapubic aspiration, and then antibiotic. And then further investigation based on if a specialist think that this child need it, then only they can do it. But most of the time, this ultrasound and MCUG done in recurrent UTI in children. But it is a good idea to mention it during the exam, because sometimes we have seen that if you don't mention it, they fail you. And we don't know why, but sometimes I think like sometimes they would just want to hear that that for children we want to rule out any structural deformity in their urinary tract. So it's a good idea that you mention it, but just say that it is ideally done in children who gets recurrent urinary infection. Okay, clear everyone? Any question? Okay, so seems like UTI is all done. Next, gastroesophageal reflux. Gastroesophageal reflux is also important. Now, many of you get confused with this term, gastroesophageal reflux and gastroesophageal reflux disease. In children, we use these two terms, and you can't interchange these two terms. So you're a GP and a mother brought her 4 months old baby girl. She says the child vomits after feeding. There are no other symptoms. Mom thinks the bottle feeding will be better for him. History, physical exam, diagnosis and management. So what is gastroesophageal reflux? Gastroesophageal reflux is a it's a physiological thing that happens in every healthy newborn. So it is the passage of gastric contents into the esophagus, which is a physiological process that occurs several times in a day in a healthy newborn. And most of the time, at 12 months of age, only 5% of the children will have this symptom. Okay? That's gastroesophageal reflux, which is physiological, which can happen in every child up to 12 months. But what is gastroesophageal reflux disease? The symptom of gastroesophageal reflux disease is if a child has gastroesophageal reflux, along with that, if the child having pronounced irritability with arching of their back, refusal to feed, loss of weight, hematemesis, chronic cough or wheezing, and apnea. So in a child who has gastroesophageal reflux, if they also have got these symptoms like refusal to feed and losing weight, hematemesis, chronic cough, or apnea, that's the time we call them as gastroesophageal reflux disease. Okay. Now, the positive finding in history and physical examination in here it was, so if you see here, gastroesophageal reflux and gastroesophageal reflux disease, those are two different conditions. Mainly, you can say reflux disease is a complication of reflux. So in this case, the positive point would be child will be vomiting after feeding, white color, which means all the breast milk is coming out, but child will be gaining weight. All the physical examination will be normal. So everything is normal. It's the only complaint is that every time after feeding, child barfs a little bit and then vomit a little bit. Okay. So that's gastroesophageal reflux. Your history and physical examination exactly the same like before. The only thing you need to add in your history is looking for this complication. So in your history, just ask about that. Few things you have to ask. Obviously, about the irritability, you can find out in the mental status. So is your child active, alert, or irritable? And then you ask about how about his sleeping and feeding. So you will find out the answer here. Weight loss also will be covered in the whale baby questions. We only have these three questions to ask. So ask about any blood in the vomiting, any coughing episodes, especially at night time, any musical sound from the chest, which is wheezing, and have you noticed that your child stopped breathing for a few seconds while sleeping? That's apnea. So ask about any blood in the vomiting. Is he having cough, especially at night? Any musical sound from the chest? And have you noticed that he stops breathing for a few seconds while sleeping, sorry. Okay. So just this will be added in the history. Apart from that, everything is same. And then you are going to explain what is gastroesophageal reflux. So you'll say that most likely from history and exam, your child is having a condition called gastroesophageal reflux. So the lower part of the food pipe, where it connects with the stomach, is poorly developed in babies. So you can also, if you have time, you can explain as simple as you can. You can say that so you can say that, Will, when you give food to your baby, it goes through the mouth into his food pipe and then into the stomach. Now, the lower part of the food pipe is not well developed. That's why sometimes the milk in the stomach can flow back into his mouth, especially when you put him down. And that is what we call as reflux. It is a very common condition where the baby vomits after each feed, but otherwise thrives well, gain weight well, so everything else is fine. This condition gradually improves with the time, especially after introduction of solids, and majority of time it will be cleared by the age of 12 months. So please don't get scared about it. It is not something serious. You can give some differential diagnosis if you have some time in here. So there is no need of any investigation at the moment, and there is no need of any specific medication. What I would like you to try is try some lifestyle modifications, such as try to give him a small frequent feeding, decrease the duration of feeding along with the time in between. You can also use some food thickeners such as Gaviscon. Try to elevate the head of the cot by 10 to 20 degrees at night, and after each feed, please do not put him immediately to sleep. Carry him for a while and then put him in cot while the head is elevated. We highly recommend breast milk because it is best for your baby. Why this was written in here? Remember, always make sure if something is written on your stem, address that concern. Don't forget it because most of the time that is your key step. So in here, mom think bottle feeding will be better for him. And if you don't comment about that, you will just miss a key step. So say that we highly recommend breast milk because it is best for your baby. Now, if this modification doesn't help in few weeks, then I can always refer him to a pediatrician who might want to start him on some acid suppressant therapy, which most of the time is not needed. Please don't get worried. As long as your child is growing well, feeding well, there is nothing to be afraid of. I'm going to review him regularly to check he is gaining weight and he's thriving well, and I'll give you some reading materials about it. At any point, if you notice that he's developing pronounced irritability with arching of the back, he's refusing to feed, losing body weight, getting cough, or any musical sound from the chest, please come to me straight away. So those are the red flags that you have given, and those are all symptoms of gastroesophageal reflux disease. Okay, so that's your history for gastroesophageal reflux and also the management. Any question with this one? If a child is coming to a GP clinic with symptoms of UTI, are we going to always refer him to the hospital? Not really. That's why I said it's not always. You always decide based on the child, how the child looks like. If it is only fever, child is eating well, no vomiting, then no need of sending the child to the hospital. For older children, we can take little bit more risk. Like if this child was 2 year old, you don't need to send the child to the hospital for a UTI. But the main problem is this is a vulnerable group of age. Like less than 12 months, children can get septic very easily. And that's the reason why we are sending the child to the hospital. But same child, if even with vomiting, if there was if the child was not severely dehydrated, we could still just keep the child in the GP clinic with and give some antibiotic and send back to home. Okay, it depends on the age. It depends on the symptoms always. No, short stay is not very common in GP setting. Okay, GP setting is think about a clinic in your country where a patient goes into a room, you find out their history, you give the medication, they go to home. That's the main GP thing. Sometimes if the patient is very unwell or you have to like monitor the patient, then you can keep them in the short stay. But there is not much of a short stay in here. It's kind of a you have to just get into the next patients in GP clinics. Good question, Dr. Kalahari. So, gastroesophageal reflux disease, can this be diagnosed clinically without investigation, or do we need to exclude other causes with simple investigation? No need. It all depends on the symptoms. If you're not getting UTI, if the symptoms are not going with anything, you don't need to investigate the child unnecessarily. Symptoms are pretty straightforward, so it will be clinical diagnosis, even if it is gastroesophageal reflux disease. Okay, now we are going to take a 5-minute break, and after that, we are going to start some of the other cases. Okay, 5-minute break, everyone. Thank you. All right, everyone, let's start again. So before I start, I'm just going to show you one thing. So RCH is still your friend in AMC Clinical. So go to the RCS gastroesophageal reflux, and you'll find out few other things that I was talking about. So this is the gastroesophageal reflux disease. You can see that investigations are rarely necessary and not diagnostic. It's only done if there is nothing else that you can do. And there is a flow chart also, that is step-by-step approach that when we start referring, so especially if there is a complication of reflux disease, then yes, you have to refer the child to a pediatrician. Okay? And consider consultation with a local pediatric team if there is a red flag present, patient is clinically unwell, and if you have tried gastroesophageal reflux disease management, but still nothing is helping, especially even after starting the acid suppressant therapy, which is your PPI, like you can try omeprazole, is usually the recommended agent. Still after that gastroesophageal reflux disease symptom is not responding, then yes, you have to refer the child to the pediatrician. Okay, so go through this guideline as well. Let's start with pyloric stenosis. You are an HMO in emergency department. A 6-week-old baby boy with vomiting brought by his mother. So 6 weeks is a very typical and very classic age for having a pyloric stenosis. Between 4 to 6 weeks, we say between 2 to 6 weeks. History, physical exam, and diagnosis management. Positive finding in pyloric stenosis. The typical onset is between 2 to 6 weeks of age at term, rarely after 12 weeks, but it can happen. Vomiting will be non-bilious, so breast milk usually will come out, and progressively the vomiting becomes more forceful and projectile. Sometimes because child is vomiting every time you are feeding, immediately after feeding, child gets hungry and can start crying. That's one of the classic signs that child is vomiting everything out. And obviously, if child is vomiting everything out, child will not gain weight and it will cause weight loss. So these are all the positive findings on the history. On physical exam, very important to look for dehydration. If you do the abdominal exam, you can get a gastric peristalsis on inspection, which is kind of a muscle contraction wave, which can start from the left upper quadrant and it can move to the right lower quadrant. So if this is the abdomen, pyloric stenosis, the gastric peristalsis can start from the left upper quadrant and lower quadrant like this. You can also get a pyloric mass, which is common in the right upper quadrant over this area, and usually it's kind of an olive-sized mass. Okay, so this will be your examination finding that you can look for. Not every pyloric stenosis children will have this finding, even if they don't have the finding. But if you have got forceful projectile vomiting, child is losing body weight, you have to consider pyloric stenosis. There is a test called feeding test. Sometimes if you want to see that if the child is vomiting after feeding, you can ask the mom to feed her, and then you can wait and see that if the child vomits afterwards, and if it looks like a forceful projectile vomiting. So that's feeding test will be positive in here. So history physical exam is same. It's only the management that you need to know. So say that from history and physical exam, most likely your child is suffering from a condition called pyloric stenosis. Do you know anything about it? No, doctor. Well, let me explain in detail. So the milk goes from the mouth through a tube-like structure called food pipe to the stomach. And from this stomach, milk then goes to the small gut and then to the large gut, and then it goes out of the body. In pyloric stenosis, the lower end of the stomach, called pylorus, gets narrowed. And as a result of that, milk or whatever the child drinks cannot pass down to the small gut, and that's why child vomits it out. And due to the vomiting, he is losing fluids from his body. He's not getting adequate nutrition, so that's why he's also losing body weight. Jenny, this is an emergency condition, and I'm sorry to say that, but there is the only fix is to go for an operation. That's why I'm going to call an ambulance and arrange for a pediatric emergency retrieval team to transfer your child to the hospital as urgently as possible. Now, in here, there's a lot to, in between, there is a lot to understand because you are not working in Australia at the moment. This will become very confusing to you. So this is a GP setting. From GP setting, for a child who is having pyloric stenosis, they will be severely dehydrated and malnourished. So you can't wait for an ambulance to come and then take the child to the hospital. It depends. So if the child doesn't look that unwell, not severely dehydrated, you can use an ambulance, like a roadside ambulance. If the child is severely dehydrated, looks unwell, very malnourished, you have to use an air ambulance for the child to go to the hospital. But what if the nearest hospital is just 30 minutes away? Are you going to use an air ambulance for it? No. So it always depends on where a GP clinic is, where is the nearest tertiary hospital. So it depends on a lot of factors. Okay. So better is to just say that this is an emergency condition, and I'm afraid that an operation is needed to fix the problem. That's why I'm going to send your child to the hospital by an ambulance straight away. I'm going to also call the pediatric team over there so that they are aware of this condition. In the hospital, he will be admitted and seen by a child specialist for further management. Diagnosis is usually clinical, but the specialist might want to do an ultrasound to confirm. They will also do frequent blood tests to check his salt and minerals level and also his acid-base level. As your child is dehydrated, while we are waiting for the ambulance to come, we're going to insert an IV line and start him on fluids. I would also advise you not to feed him from now onwards because this can make things worse. If your child keeps on vomiting, even after stopping your eating, then the hospital can insert a tiny plastic tube through his nose down to the stomach to remove any content of the stomach to stop the vomiting. Once your child, so this is NG tube insertion, right? So once the child is stable, most likely an operation will be needed to fix this problem. Your child will be able to eat and drink usually within 6 to 8 hours after the operation. Once the problem has been repaired by the operation, it is unusual for it to come back again. Jenny, I can't even begin to understand that what are you thinking at the moment. And I know that you are not expecting any of this, but I want to assure you that your child is going to be under our care, and the team and our team will do the best to make sure he is fine. If you want us to call your friends, family members, or anyone that you want to be with you right now, please let us know. We are more than happy to contact. Okay, so that will be your finishing in here. You can give some reading materials while the parent is going to the hospital, and you can say that you are going to review the child once he is discharged from hospital. Okay, so always remember these are the cases where parents become really very worried. It's understandable, right? Because if a child is brought to you with vomiting and you say that child is needing a operation, it's a 6 weeks child, the parents will be terrified about it, right? So you have to act in that way, that you have to give those reassurance, you have to be empathic to the parents, otherwise why they're here with you, right? So anyone can say that your child has got this, but it's all about how empathic you are and how much caring you are. In exam, this matters a lot. As I'm saying time to time, you will come to understand it at one point that this is the main part to pass the exam. Okay. So the management mainly, you have to explain what is pyloric stenosis. You have to explain how this occurs and why it is an urgent thing. And then obviously all you can do is to send the child to the tertiary hospital by ambulance. Then the management first start with an ultrasound, IV fluid, some blood test with like mainly full blood count, urea electrolyte, creatinine, acid base level checkup. So ABG or VBG, those will be the main investigation. Once the child is stable, then operation will be done. Okay. Any question with pyloric stenosis? And Dr. Sinavi, where we can add food thickeners. That's the last topic, right? Reflux question you are asking. So food thickeners you can add to sometimes what happens that you can express the breast milk and then you can add the food thickeners in the breast milk. If the child is having formula milk, then with the formula you can add it. So it depends. So without any scan, how can we be sure? This is a clinical diagnosis. It's a 6 week child who is vomiting after feeding, non-bilious vomiting, and there is no sign of any infection, so no fever, and you haven't got any other findings suggesting otherwise, and also child is not gaining weight. That's all that we require. So everything goes with pyloric stenosis, right? So that's why you are ruling out all of your differential diagnosis. And in a GP setting, you can't arrange an ultrasound immediately. So all you can do is giving a provisional diagnosis, send the patient to the hospital. If pediatrician wants to do a scan, they can do it. Most of the time they don't require it, but they can do it if they want. Age group for pyloric stenosis is between 2 to 6 weeks of age. But any age group can get it, especially any infant can get it. So Piper is a pediatric infant perinatal emergency retrieval. So that means what happens that it is a emergency retrieval for children or infant who are seriously unwell. So that's an air ambulance retrieval. So if this same child with pyloric stenosis was in a rural hospital and tertiary hospital is 3 hours away, then you have to involve a air ambulance through this Piper. And the Piper is basically a air ambulance which will take this child to the tertiary hospital urgently. Okay. All right. Moving on to the next case, intussusception. You are a HMO in emergency department, and a 5-month-old boy with multiple episodes of screaming for the last 6 hours coming to your ED, vomited twice in the last 3 hours. So you can even understand from here that it's a multiple episodes of screaming and vomiting. So obviously you will start with your initial approach, and in here the main presenting complaint is screaming and vomiting. So you'll start with the screaming. So can you tell me a little bit more about these screaming episodes? So they will give you some information, but you want to know since when it started. Anything in particular happened before these episodes? Is it continuous or episodic? How many episodes so far? And does he draw up his legs while crying? And does he turn pale? So this is a very important feature that with the screaming episodes, children will draw up their leg so that they're in, as if they're in severe pain. They can sometimes even clench their fist and they can turn pale. And after the screaming episode, you will be asking the same questions. So ask vomiting questions, ask all the differential diagnoses one by one. You will find out that intussusception, it will be a bilious vomiting, so greenish vomiting. Sometimes they also have a loose stool, which is that red currant jelly-like stool that you can get. So many times intussusception, there will be a loose stool or a red color stool. The parents can complain. Okay, and other questions are all same like before. Physical examination also same, but the finding that you can get here, sometimes there can be tummy distension or abdominal distension because intussusception is basically an intestinal obstruction. You can also feel a sausage-shaped mass. You can get emptiness in the right iliac fossa, and sometimes on the bowel sound, you can get an alternating high-pitched bowel sound with absent bowel sound. So many times nothing can be found on examination, and then only time you can get this finding if when the child is crying. So that's also one of the things that you can look for. So, but during palpation, you can get a sausage-shaped mass. You can also get this empty feeling on the right iliac fossa. Those are the findings you will be looking for on the card. Plus, you don't forget about doing a paranal inspection, especially looking for this red currant jelly. There was a case I think few months or years ago, where it was a face-to-face case, and you have asked all the history, physical examinations. You can't find out any good history from the parent so that you can diagnose with anything. After physical exam, there was a task about do paranal inspection on the dummy. So they gave a dummy on the exam table, and you just needed to remove the diaper. And when you remove the diaper, you will see a red currant jelly-like stool. And that was actually the only finding given. So sometimes it can be quite confusing in the exam, but don't lose hope. There will be something given so that you can diagnose the condition appropriately. Okay? So positive point in the history is episodic crying with child drawing up the legs. During the episodes of crying, child looks pale, lethargic. There is some bloody red currant jelly-like stool. Okay? And physical examination finding, we already know. So once we know that this is the intussusception, how we are going to manage this? Say that based on the history and exam, most likely your child is having a condition called intussusception. Do you know what it is? No, doctor. Well, it is the sliding of one part of the gut into another. And because of this sliding, the bowel can get blocked or obstructed, leading to these severe painful episodes and vomiting. Because the bowel can get blocked or obstructed, if the bowel doesn't get blood supply for a long time, it can become irreversibly damaged. That's why it is an emergency condition, and we need to admit your child and involve a child specialist. I'm very sorry to give all of these informations to you, but I want you to understand that your child is safe with us, and we have a very good team of pediatricians here. In the meantime, please do not give any food or drink to your child. We are going to start an IV line and start him on IV fluids. Specialist might want to do an ultrasound and X-ray of his tummy to rule out any other diagnosis or any other conditions. Once it is confirmed, treatment is given by the specialist. So a child specialist, a radiologist, and a pediatric surgeon will come and review your child. And most of the time, initial management is called an air enema, where they will pass a small tube at his back passes, through which air will be passed to unblock this gut. Please don't get scared. Throughout the procedure, your child will be monitored by the specialist and he will be in sleep, so that he will not feel any pain during this. Most of the time, this procedure is helpful and quite effective, but in case it is not effective, then a surgery might be needed. And at the end, say some nice. So you can say, Jenny, I can't even begin to think how are you managing right now. And I do understand it came as a shock to you. And I want you to understand that you did the right thing to bring him here as early as possible. And we have the best team here to take care of him. If you have any questions, feel free to ask me anytime. If you want me to call any of your friends, family members, or your partner, please let us know. We will be more than happy to connect. Thank you. Okay. So finish with something reassuring. They will be very happy. Any question with intersusception? So you can see that still we are doing the cages with just a single history format, right? So that's the cluster-wise approach, which is brilliant and which is really, really helpful for you. All good, everyone? No question? Same intersusception also has a RCH guideline. So I would say have a read at least once. Great. Next one is incarcerated hernia. So two kind of questions are here. A 5-month-old baby coming to your GP clinic with his mother because of sudden onset intermittent screaming with a few episodes of vomiting. Older brother has got a recent onset of gastro. So sometimes even this screaming can come with incarcerated hernia. It's not always that it is intersusception, right? Because it looks exactly the same question, but the diagnosis is different. And the other one is a 3-month-old irritable baby for 3 weeks. Today, mother noticed a lump on the inguinal area. So this one, history, physical exam, diagnosis, and management. So this is for 3 weeks, child was irritable, but now the mother has noticed an inguinal lump. So that's most likely also an inguinal hernia, but this is an obstructed hernia mostly. So in this case, history is totally same. Sometimes we have seen that when you ask about, have you noticed any lump or bump on his tummy or on the groin? Even with the hernia case, sometimes the role player says no. So don't just stop thinking about hernia if the role players say no, because on physical exam, you can find out a hernia finding. So don't forget about checking the inguinal orifice. And in the inguinal orifice, if you get a tender, irreducible inguinoscrotal swelling, then you know this is a obstructed hernia. Okay. So many times what happens that on the physical examination card, they can give you a picture with the incarcerated hernia, and you will be seeing a red inguinoscrotal lump. So that will give you the basic idea that this is most likely a irreducible or incarcerated hernia. Okay. So from history and exam, most likely your child is having a condition called incarcerated hernia. Do you know what it is? No, doctor. Well, a hernia is a protrusion of a part of the gut or fatty material through a weak point on our tummy wall. It is usually seen as a bulge or a lump under the skin. In a simple hernia, the bowel and this fatty tissue are able to move freely in and out of the defect. And that is what we call as reducible hernia. But in some cases, if the part of the bowel becomes trapped and cannot return back to the tummy, then it has the risk of having its blood supply cut off. And that time we call it irreducible or incarcerated hernia. Because the bowel doesn't get its blood supply, it can get irreversibly damaged. That's why it is an emergency condition. That's why I need to admit your child in the hospital and also involve my senior and a child specialist for further management. Please do not feed him or let him drink water. I will put an IV line and start with IV fluid. Most of the time, a specialist will go for a surgery to put the blocked gut back inside. Okay. And then you have to just say something reassuring, say that please don't get scared. We will do our best to manage his condition. We have a very good team of doctors here. Okay. So that's called incarcerated hernia management. As you can see, it's more or less same in the management also, just the explanation is different. Okay. How do we know that if it is a reducible hernia or it's a irreducible hernia? Very easy. The reducible hernia, it will be freely mobile and child will not complain pain on that area. There will be no vomiting. But when it is an obstructed hernia, that means the lump is not reducible anymore. It will be tender and sometimes, especially if it is a blocked bowel, they can also have a vomiting. Okay. So that's your incarcerated hernia case. Any question, guys? Next. Now, the first question, we will not ask about gastro symptom. Older brother has got recent onset of gastro. Yes, you will be asking about it. So, because in the history, you will be ruling out differential diagnosis. It can be a gastro, we never know. And most of the time, it can be just a trap. So, whenever they give you like older brother got gastro, most likely it is just a trap so that you think that this case is a gastro also. All right. So, you'll be obviously trying to rule out, but if you get a inguinal hernia, then that's the most likely ones. The second case is most likely is a reducible hernia because it's been for 3 weeks and there is a hernia over there which is causing the irritability. And there must not be any vomiting or anything else, just a lump. Any X-ray available in here? No. Umbilical hernia is a different management, but inguinal hernia, especially if it is obstructed inguinal hernia, management is surgery. But for umbilical hernia, sometimes you can even wait until 4 years. So you don't need to like send them for surgery all the time. Yes, sometimes there will be X-ray. So this is the case where you'll get an X-ray, duodenal atresia. Let's start this one. And I think this is our last case for tonight anyway. So you are working in a small country hospital as an HMO. You have been called to talk to a 27-year-old mother, Janelle, who gave birth to a baby boy 24 hours ago. She started breastfeeding, but he has vomited several times some greenish fluid and hasn't passed meconium yet. The neonatal checkup did not reveal any pathological finding, especially anus was present. An abdominal X-ray is provided. Take a brief history. Now, the history sometimes could be history from the nurse, could be history from the mother. Explain the X-ray to the mother. Discuss the most likely diagnosis and management with the mother. Okay, so the history, and this is the X-ray that has been provided. You can see the double bubble sign. So we'll come to the X-ray just in a bit. So first of all, in this case, you will introduce with the mother and then obviously say sorry that it's been happening with her, but also congratulate her. She just have a baby, right? So, hi Jenny, this is Dr. Arshan. I'm one of the HMO or I'm one of the junior doctor in this hospital. Very nice to meet you. And congratulations on your baby. What did you give him any name? Okay. So you start building a rapport. And after that, if you know the name of the child, like let's say Sam, so I'm very sorry to hear about Sam because he has been vomiting since he is born, right? Yes, doctor. Well, please don't get scared. We are here to help you and trying our best to find out what's causing this. I would also make sure your SAM is vitally stable. So we are going to check everything. So say all of those and then start asking questions about the vomiting. So same vomiting history. And after vomiting, you can ask some of the differential diagnosis as we asked. So ask all the DD as relevant, especially intestinal obstruction, UTI, all those questions you will be asking here one by one. Okay, nothing is different in here. The only thing I would ask you to add is in the birth history. So you're asking that how was the birth? Was there any complication? Is he a term baby? Just ask the mother that did you have Down syndrome screening? Because most of the time duodenal atresia is common in Down syndrome babies. So ask the mother that did you have a Down syndrome screening or not? Okay. So apart from that, everything is same. Your next task is to explain the X-ray to the mother. Explanation of X-ray is a very commonly asked task in the exam. Sometimes you will explain it to a medical student, to a patient most of the time, or to the examiner. So examiner or medical student is very less. Most of the time, they give you to explain the X-ray to a patient. So how to explain an X-ray? So say that, thank you so much, Jenny, for all the information. Now we have done a X-ray of your child tummy. Let's have a look together. So have a look on this X-ray, and you can see that this X-ray is mainly covering his tummy, including the lower part of his chest and the upper part of his hip and pelvis. On X-ray, there are some shadows which looks white and some looks black. Black is mainly which contains air, and white is basically which consists of bone or contains fluid or blood. Now, if you see that just on the upper part of the X-ray, you can see some black shadows on the both side. That is his lower part of his chest. In the middle, you can see the whitish shadow, which is his heart. And then if you come down to the tummy, you can see two rounded structure. Can you appreciate that on his tummy? Yes, doctor. That is what we call as double bubble sign. And this has a very specific classic phenomenon, and we get it in a condition which we call duodenal atresia. And that is a part of a small bowel obstruction. So small bowel obstruction means that when you are giving milk to your baby, milk flows from the mouth into his food pipe, and then it goes to the stomach and then to the small gut. Now, duodenal atresia means that when the first part of the small gut known as duodenum is absent. That is what we call as duodenal atresia. That's why the milk or breast milk that you are giving, it cannot reach to his gut because that part is absent. And because of that, every time you are trying to feed him, he's vomiting it out. I'm very sorry to tell you all of this. I can't begin to imagine how are you feeling right now, Jenny. But I had to let you know that this is an emergency condition, but it can be fixed. And we have a very good team of pediatric surgeons who deal with this kind of cases every day. So all we need to do is to make sure that this can be fixed with an urgent operation as early as possible. Okay. In the meantime, we are going to insert an IV line, start with IV fluid, and also please stop giving anything by mouth. If your child keeps on vomiting, then a small tiny tube will be passed into his stomach to 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 remove any other contents to make sure he's not vomiting anymore. The outcome of the surgery is very good, and sooner we manage, the better it is. After the surgery, most of the children usually can eat and drink and they can have a healthy life. And most of the other part of the surgery will be discussed by the pediatrician in details. Okay, and lastly finish with some reassurance. Okay, so that's duodenal atresia, very, very important case for exam. Did you understand how to explain the X-ray to a patient? So that's all about the class today. Now, few other cases which sometimes we have seen coming in exam also, which will be discussed in our question solve class. One of them will be, sometimes they give you a X-ray of intestinal obstruction in children, where you get a multiple dilated bowel loops. Let's show you the X-ray, how it looks like. So you can get any of these dilated loop of bowels like this or any of this. So the diagnosis will be, if it's the central part of the tummy is having the dilated loop of bowel, that's a small bowel obstruction. If you're not sure that if it is a small or large bowel, the diagnosis you can give is intestinal obstruction. Okay, so that's one of the time we will discuss it in our questions in our role play class anyway. And there is also another condition called tracheoesophageal fistula. In tracheoesophageal fistula, what happens is that, let's see, I'll just show you a picture so that you understand better. So we discuss these cases anyway. Just remember a few things before we discuss. So tracheoesophageal fistula, there is a case, not very common, but we should know about it. So you can see that this is the esophagus, and then that's the trachea. In tracheoesophageal fistula, what can happen is that sometimes you can get, so this is the most common one. So the esophagus can end in a blind pouch like this, and the distal esophagus can get connected with the trachea. Okay, so every time child will have some meal, it can't go in, right? Because it's ending here. So what can happen? Child will vomit it out. During vomiting, some of the vomiters can also end up in here, in the trachea, and child can develop aspiration pneumonia. So children can develop vomiting after feeding, and that will be a non-bilious vomiting. Whereas in duodenal atresia, because it's a part of intestine, it will be a bilious vomiting. That's how we differentiate these two. And there is also some other things. Because of aspiration, child can develop shortness of breath, sometimes even frothing or bubbly frothing coming out from the mouth. Children can also have sometimes choking, regurgitations, and all the features of aspiration pneumonia can be there. And also child can get quite cyanotic in here. So those are the symptoms that we will be looking for. If you do a X-ray in these children, you will find out a very peculiar thing. The NG tube, so when you pass the NG tube, it will curl like this. I'll show you how it looks like. What you see here is called coiling of the NG tube. Can you see that they tried to insert the NG tube? The NG tube is supposed to go to the stomach, up to the stomach, right? But you can see this coiling of the NG tube. When you see this coiling of the NG tube, and you can see some gas shadow also in the stomach, okay, or in this area, that means some of those gas came, you see here. So sometimes what you can see in tracheoesophageal fistula, because of fistula, some air can come into the stomach, right? So you can get the gaseous shadow on your tummy. So when there is a gas shadow on the tummy like this, and also you can see this coiling of NG tube, that's tracheoesophageal fistula, which is also I have seen to come in exam, but we normally discuss that in our question solve class. Okay, but just keep an eye on it. Remember what we have discussed. Some other questions. So Dr. Kalhari, non-obstructed hernia, do we need to send the child to hospital or outpatient follow-up? You don't need to send the child to the hospital. First of all, you can order an ultrasound as outpatient, find out what's the content, and then you can do an outpatient referral. Tracheoesophageal fistula can cause IUGR. Is there any possibility that we will get X-ray with coiling tube? Yes, you can. There is a case like that. Okay, we'll discuss that case anyway later on. So that's all about the vomiting cluster, and I'm sure that you have understand that sometimes just doing a single cluster can cover how many cases, right? Now, this is our last free 2-week session. I hope that you enjoyed it. And if any of you still wondering to join the session, this is actually the last time to do it. We always advise you that once it's even better to be in the course right now. But if still some of you are wondering that if I should join or not, I would say this is the last time to do it. Our orientation class is in 3 days, and it's must to join that class. And it's a very important class anyway. To give everyone again an idea about this new course. So the course has basically started on 7th October, and we are doing these 2 weeks free sessions with you. All those free 2-week sessions, the recordings are given in your Facebook group and also in the YouTube. So if any of you missed it, you can always get it in our Facebook group. And also those of you who are part of the course already got it in your portal. We took trial class on 23rd September, where we did a MSc theory class. And then throughout these 2 weeks, we have done psychiatry role play. We have done 2 random role play sessions with Dr. Cynthia. We have done cardiology. We have done a cardiology role play session. And we have done today vomiting cluster. Okay. So a lot of things we have done in 2 weeks, as I can see. I'm hoping that you have liked the session so far. The course will include everything that you need. There is nothing else that you can ask for. The course is divided into theory-based and role-play-based sessions. So we do full theory based on cluster-wise approach that you have seen. Role-play of recent and past important cases. We cover 4-year sample questions with notes on even back up to 2019 or 2018. So there's a huge collection of pages in our portal. It's not only just notes, there is also all these 4 years, obviously not 2024, up to 2023, all the recorded sessions on the cages that we have done, all those recordings are provided in your portal. Already it is there, and we keep on adding as we go. So it's a huge collection of cages that can cover almost every case that can be important for exam. Physical examination is a vital part of AMC clinical preparation, and we have one of the best note and best classes for it. And we cover physical exam with 9 classes. So 1 month will be solely on physical exam. And that is, you will understand how much care we do for your physical examination classes. We also try to take online mini mock exams, usually every 4 to 6 weeks. Recordings of all the classes will be provided in your portal. Notes will be there. And there is a important session coming up on this 28th of October. So just in few days on job hunting, registration, everything. So there is a career guideline session coming up. Make sure you join it. And also we discussed about CPD's course completion certificate. The cost is $899. And if you join now, you can even do it with 2 installations. It's a 5 months duration, 3 days a week class. And the classes are like this, 8:30 to 10:30 p.m. Sydney time. Okay. So that's all about the course. Is there any questions that anyone having? You can ask by unmuting yourself, or even you can write it in the chat box. Yes, so Dr. Jamshina, so duodenal atresia, because it's the intestine. Anything in intestine will give you greenish vomiting, so bilious vomiting. Okay. Meeting ID will be different. So meeting ID will be provided. So for Wednesday, this is a course student class. So it will be only provided to the course students. Okay. Any other questions?
Yes. Hi, Dr. Arshan. Um, my name is
Yes.
Rama, and I'm actually one of the students at BIFKI group.
Yeah.
So I was thinking about joining the clinical course as well, but like I wanna know if it's um, because like for the BIFKI one, we have to study before and we don't know the cases. So will it be the same here, or will it be like discussion and like the case, like the role play will be after we discuss the cases?
So there are two different kind of cages. So Pesky, I know that they provide you the topics before the class, but I know that sometimes they give it maybe 1 or 2 days before the class, so it might not be very helpful. The main reason is that the theory classes, you will know what cages we are going to do because the notes are provided already. The role play classes that we do, that's taken every classes are new classes, and sometimes even it can take a mentor to write all the notes up to your class because they had to make 6 or 7 classes in a week, and all of them are new cages, so it takes some time for them to make those notes also. So you might not know the cages for random role play sessions. And also, we don't do that because it is known as random role play sessions. And what we try for everyone to understand that in exam, anyone can get any kind of questions in front of their eye. And these random role play sessions actually prepares our student for those kind of surprise that can happen in the exam. So random role play, you will not know what kind of cages we are going to do. You will get the note after the class. But for theory classes, theory questions, or theory role plays, you will know.
Yeah, and you will be the main mentor for this class.
Yes.
Okay, thank you.
No, Dr. Rabab, thank you. And for hard copy of notes, Dr. Hajim, I can't advise any specific notes. I know that Marwan notes is not bad. So yes, if you want, you can have this with you. It's fine. But our notes has everything that you need already, and we we don't copy paste anything. We write it based on the guidelines. I know that I have changed these notes several times based on the guideline change time to time. So that's the one of the most updated guidelines you can get from anywhere. All good. So that's it for tonight, guys. I'm hopeful to start the new course with you, and hopefully you'll like it and you will reach your destination as you want. Thank you. It was a very good 2 week sessions with all of you. Take care. Bye.